Okay, welcome to rounds on August 23rd. Hopefully I will get this to advance to the next slide. There we go. Okay, so the first case that I will be presenting is a 13-year-old Pomeranian. There's a bit of a long history here, but the patient had an encounter with a cat and then had a bit of a long history. So that was early July, and then was treated with various methods, and also had some systemic signs that may have been confusing the picture a little bit, including some vomiting, maybe some coughing. And then let's see here. So they say that the left eye here, this one, was ophthalmic with severe hyperemia, and they recognized a previous corneal perforation. Ocular ultrasound revealed an irregular anterior lens capsule, hyperechoic material in the anterior chamber. And so they tried to stabilize the patient for the other systemic issues that were going on, and then they did an enucleation. So this is the globe that we received. We hemisected it, and actually there was a dorsomedial paraxial tan spot, which actually you can see here. It's not at the cut edge, but deeper to that. The globe is filled with exudate. The lens is opaque, and this material here is pretty consistent with lens capsule, which is discontinuous. And so there was definitely this corneal perforation and this exudate inside the eye, and a pretty rockin' cataract, as I like to call them. So let's go to our microscopic view here. Okay, so I actually got multiple deeper sections of this eye, and this is one of the deeper sections, which is why we cannot see the optic nerve head. The exudate that was so obvious in the gross photo is not as prominent here in the subgross. But there is a defect there in the cornea, which maybe when I get that into focus in the center.
Exit and move to the view. So go here, and it should be instead of standard, go to widescreen. There you go.
Okay. All right. Oh, there we go. That's nice. That's nicer. Okay. So here, when we look at this deeper section, there's a nice defect in the cornea right there. So we will go ahead and go higher mag and look at what we have there. So there's that nice defect. It's surprising that this cat, the dog had an encounter with the cat in sort of early to mid-July, and then lived with this for, I don't know, maybe 2 weeks or so before they enucleated, because this defect does not seem to have healed at all. There's no reepithelialization there, and it's basically filled with this fibrinosuppurative exudate, which does extend right down into the globe and is continuous with this exudate in the anterior chamber. And handily, it also corresponds almost directly with a discontinuity in the anterior lens capsule. And then we have disruption and loss of the cortical lens fibers with inflammatory cells inside of the lens capsule. And you can see some of those inflammatory cells are maybe lining up along the edges of these still intact lens fibers. So we have a true phakitis here, a suppurative phakitis. Then, as far as the rest of the globe goes, there is a very nice pre-iridal fibrovascular membrane, or epiphyme, that was probably contributing to decreased aqueous humor outflow. They actually had diagnosed glaucoma. I didn't mention that. And so there's exudate in the anterior chamber, exudate in the posterior chamber, and and then the vitreous. And the lens capsule is actually multifocally discontinuous. So you can see one end of that lens capsule is present there as well. So this lens capsule was ruptured multifocally or penetrated multifocally, if we're going to blame the cat. The vitreal exudate is actually more just proteinaceous with a smaller number of inflammatory cells and fibrin. All of the sort of subtle fibrillar eosinophilic material in the background here is fibrin. And then let's see what the back of the eye looks like. Oh, that's right. So this is the deeper section without the optic nerve head. The retina is kind of, okay, take that back. Here, the retina becomes completely necrotic, which is probably associated with the intraocular inflammation. So I just wanted to show one of the other deeper sections to show you some organisms that are in the lens. Kind of interesting here, actually. So here's a little group of bacteria that are surrounded by neutrophils. So we got a little, very nice little bacteria. Oh, wow, very sensitive. Bacterial colony. They're surrounded by neutrophils. So we do have at least intraocular, intralenticular might be a little bit debatable considering how wide open that lens capsule is, but let's call it intralenticular bacteria. So let's go back to our PowerPoint. Okay, so we have lens capsule rupture with a suppurative phakitis and intralenticular bacteria, and we like to call this disease septic implantation syndrome. There was an obvious corneal perforation with suppurative keratitis and peripheral stromal vascularization, and then a severe fibrinosuppurative endophthalmitis with other changes, as well as fibrovascular membrane and synechia formation and secondary glaucoma. So this is a nice example of a documented cat encounter for a patient that then immediately led to corneal perforation and intraocular disease or inflammation. We often get globes with lens capsule rupture, suppurative phakitis, and intralenticular bacteria that don't come with that history. Sometimes the interval between presumed or like onset of eye problems and enucleation can be months, sometimes years. Or like we'll get a globe where they say like, oh, well, there was, this eye inflammation, like 6 months ago, but then it cleared up and then all of a sudden the eye exploded again with inflammation. That's pretty common for this disease. This one is a little bit unusual in that the inflammation was a little bit more widespread inside the eye. The more sort of quote unquote classic septic implantation syndrome cases that we see, the inflammation is much more like lens centric. So it's like in the lens capsule and immediately around the lens, but not necessarily spilling out and affecting the other ocular chambers quite as much as it was here. The very open corneal perforation may have had something to do with that. So that corneal perforation obviously never really healed very well. So there we go. That's the first case. All right, our next case is a 9-year-old German Shepherd. We got the left eye. They diagnosed anterior uveitis and secondary glaucoma and blindness. The dog also had superficial ulcerative keratitis and a cataract. Oh, that was the other eye. Sorry, no cataract in this eye. And then the very important bit of information that they gave us that I'll share with you to increase your learning experience is that the dog also has disseminated aspergillosis. So when we received this globe and hemisected it, this appearance of a very specific inflammatory exudate in the vitreal space and in the vitreous is classic for fungal vitritis. And German Shepherds are well known for developing systemic aspergillosis. And so this whole case just read the textbook, which is why I took the photo, because I was like, this is perfect. So we have a lens, we have the eye. As I said, there's this tan exudate in the vitreal space, which is probably fibrinosuppurative, and I will prove that to you when we look at the slide. And then there's a little bit of, so the retina is detached, which is what we're seeing here. Whoop, whoop. And then there's some hemorrhagic exudate in the subretinal space, and then some proteinaceous stuff in the subretinal space as well. Maybe a little bit hard to tell, but I will tell you that the iris leaflets are firmly adhered to the front of the lens capsule. So we have some nice posterior synechia there as well. So I think that's mostly what we can see On the subgross, the cornea itself is actually pretty unremarkable at the subgross level here, or at the gross level rather. So here is our subgross view. So as I said, the cornea is pretty unremarkable. There's a little bit of stromal vascularization. Those iris leaflets really are just stuck to that anterior lens capsule here and here, and then bowed forward. So that's characteristic of what we call iris Bombay, which means that there is 360-degree sneakiation of the iris to the lens, and the aqueous humor builds up behind it and causes billowing forward of the iris leaflets. The lens itself is pretty unremarkable, and I messed up and said the cataract of this dog is actually in the patient's other eye. And then as we move more posteriorly into the globe, we can see there's all this purple stuff in the vitreal space, and purple usually equals hypercellularity. And I'll tell you right now that that's all neutrophils. There's also a lot of pink stuff around as well, and that is increased protein, which in this case includes fibrin. The retina is detached, as I said, and there is subretinal hemorrhage. So that's mostly what we can see at the subgross level. So we'll go ahead and jump up to the microscopic level. So as I said, front of the eye, pretty boring actually. So here's that corneal stromal vascularization. When we look at slightly higher mag at the iris and its relationship to the lens, over here, there is a pre-iridoid fibrovascular membrane that's not as obvious in this case as it was in the other case, but it also continues across the anterior lens capsule as a pupillary membrane, which is what the arrow is pointing at right there. And then we have really convincing sneakiation of the iris leaflet to the lens capsule and the billowing forward, as I said. Okay. So let's get to the meat and potatoes of the case. So as we move back, as we see, there's all this hypercellularity in the vitreal space, and the vitreal space is kind of compressed because the retina is detached, pushing everything forward. When we look at higher mag, at this exudate, all of what we're seeing here are very degenerate neutrophils. So this is a suppurative exudate. All of this material here is actually this fibrillar eosinophilic material. And this, you might think, could be fungal hyphae. And in fact, there might be some here, but a lot of this is actually fibrin as well. In fact, actually, yeah. So the finer stuff, like right in here, is fibrin, but then you can actually see that these little end-on purple guys and some of the more linear purple guys like this right here are fungal hyphae. So we can actually see them on the H&E, but I did get a PAS, so I'll show you that in a moment. But let's continue with looking at what else we have here. So there's like a bajillion fungal hyphae in this eye. So the retina is detached. There is variable atrophy. So here's an area right here under the green arrow where the outer nuclear layer kind of disappears. And there's also loss or shortening of the photoreceptor inner and outer segments, which is pretty common when you have retinal detachment because those inner and outer segments degenerate pretty quickly. And then there is occasional foci of necrosis where the retina just loses all of its layering. And so that is necrosis. So here's the subretinal hemorrhage, as I mentioned, and that's the most stuff that we're seeing there on the H&E. I'm going to focus on this area when we look at the PAS stain, because there are a bunch of fungal hyphae here, which you can actually see on the H&E, as I pointed out earlier in that other spot. So there they are. That's as high as we can go on this magnification, on this scope at the moment. So I'll just quickly show you the PAS stain. Focusing on that same area. And PAS stains will make the fungal hyphae pink. And then fibrin does not stain pink. So what we see here are all those myriad fungal hyphae. Tons and tons and tons of them. I couldn't find really convincing septations, so they look pretty aseptate to me. They have parallel walls. I think they range from maybe 4 to 6 micrometers in diameter. And then occasionally I was able to find sort of right angle, non-dichotomous branching, like that guy. Oh, wow. Like maybe this right here. And then, as I said earlier, the fibrin, which can sometimes mimic fungal hyphae, does not stain with the PAS stain. So all of that green fibrillar stuff is actually the fibrin. So I thought that was a pretty nice contrast for how the stains differ. So we assume that the fungal hyphae arrived in the eye via blood, via the vasculature. I looked really carefully at the retinal and choroidal blood vessels here and didn't really see any convincing intravascular fungal hyphae, but that's still our assumption. So there we go. So this is a nice case as far as a pathologist perspective of fungal vitritis associated with systemic aspergillosis. Sometimes we receive the globes and diagnose this, and they don't know that the dog has any kind of systemic fungal disease, and so then we make it known to them as fast as we can that this dog has systemic, well, presumed systemic fungal disease, and that they need to confirm that and then try to initiate treatment. So we haven't heard any follow-up on this patient, so I'm not sure if they have initiated treatment yet. Presumably they have. So that is all I have for you, and Megan is up next. I'm going to extract myself. We have here. Okay.
Even wires.
Yeah, trying to roll over them with the
microscope.
all right.
Okay. There's 2 mice. There we go. The chair.
Try not to move the chair.
Try not to move the chair. All right. This is a 9-year-old spayed female domestic short-haired cat. So wait, yes, I definitely do. This is a thesical swollen globe remnants, they call it. Cornea not visible on exam, but perforation noted at enucleation. The cat has a history of lens luxation, cataract, keratitis, ventromedial strabismus, on exam by a different vet. Thank you. So, on gross examination, first of all, still in that chair. Here's the optic nerve down here. We have a tag of conjunctiva up here. The cut may be a little bit peripheral in terms of catching cornea, which is why part of the reason why I think it kind of looks like we have sclera all the way around. But regardless, the main feature is definitely right here for everybody to see. The uveal tract is pretty extensively thickened, distorted, replaced by this tan white tissue. This tissue also actually extends underneath the choroid. So the level of the choroid is roughly here. You can follow it as this brown line, and the retina on top. And this tissue is invading into the suprachoroidal space beneath that. The lens is present and probably unstable to some degree, and also has a cataract. So let's squeak. Let's switch to Desto. 11. There we go. Right. So we have the globe positioned with the optic nerve down here. We have the retina coming out back here, and that luxated lens here. The entire surface of the globe is covered by what looks like conjunctival tissue, which again could be either, it could actually be either that we're peripheral in catching the cornea, or symblepharon, or maybe some combination of the two. And the tissue here is a little bit too purple, and so we have too many cells. So looking closer at what is causing that. We can already see a lot of these tubules coming into view here. And a thick sort of purple layer lining the inside of the cornea. You can actually follow the back of the cornea here. It's very, very wrinkled, part of the thesis bulbi they described. And this similar tissue is effacing the iris and the ciliary body. You can just make out some of the plicae here, sort of embedded in this abnormal tissue. And here's that area where it was invading sort of the choroid or suprachoroidal space with a big necrotic center and similar tissue at the edges. So just giving you a tour around the globe. We've got it attached to retina as well. Here's similar tubules in the choroid and suprachoroidal space. And some of these tubules at this level have a little bit of proteinaceous fluid in the lumen. So it's homogeneous, it's pink, it's full of protein. So that was a tour around the eye. At this side, the iris is actually still easy to define. We can make out where it's at. The pigmented posterior iris epithelium is still here, although it's disrupted by these abnormal cells. Then you can see these cells carpeting the entire surface of the iris all the way around and then invading stroma. And the iris stroma itself is very severely edematous. So really invasive. Now let's look closer at who the cells are. And they're epithelial cells, if you hadn't already guessed. They often form these tubules, and then they form these papilliferous projections into the tubular lumen. And in particular, one of the features that I thought would make this a nice one to show, even though I think we kind of recently showed a really aggressive carcinoma in a cat already, is this feature here. So the lining of this tubule here is sort of pseudostratified columnar. And these cells here are exhibiting, we can actually go closer, this interesting feature where they have a brush border. So got these sort of little fingers coming off the apical end of these neoplastic cells. So that is a ciliated apical border. And probably the most common metastatic carcinomas to the eye of cats are respiratory carcinomas, especially pulmonary, but maybe also nasal is possible. And with this pseudostratified columnar appearance in some areas of these epithelial cells and the ciliated border, that sort of adds an additional level of suspicion that they should probably go check the lungs on this kitty. And to review again the features of metastatic neoplasm, which is why I call this metastatic carcinoma, the extensive carpeting of the intraocular surfaces is part of what we call metastatic pattern in this case as well. So this is a metastatic carcinoma in a cat with the feature of that nice ciliated border of the cells. Yes. There we go. So if there are any questions about that, I'll do the next case. This is it's one where they have the date of birth in there instead of the age. Math. This is a roughly 15-year-old, I want to say, Chihuahua mix, neutered male. This dog has a history of trauma to the left eye in 2004. So kind of an old trauma. Recently, there's been corneal degeneration with subepithelial mineral and epithelial sloughing. And the globe was non-visual and thesical, so they elected enucleation in this case. The other eye is unremarkable. So a really old trauma in this case. We'll start with the gross. So we have the cornea up here. We have the iris coming in. I believe they said they did not. Okay, never mind. We don't have an obvious lens in the middle of this globe. So that's an interesting feature already. And then the other thing that's a main feature that you probably have already noticed, if you follow the sclera around, there's this area where it becomes a little disrupted, maybe it's slightly curled inwards. And then you have this white tan tissue bridging the gap and extending into the globe from there. The orbital tissue here is also, or was also likely very firmly adhered, which when we're grossing a globe, if we have a globe where there's this slight sort of divot in the sclera and the orbital tissue is very hard to move and tightly adhered to the back of the globe, that's a key red flag to go looking for a site of rupture. So we have a ruptured globe in this case that has become thesical, and we don't know where the lens is at. So we'll take a look histologically for what we can see. I guess before we move on from the gross photo too, there's also some degree of distortion of the reticocorneal angle here with some pigmented uveal tissue a little bit higher than we might expect here, and maybe a little bit of an angle recession, maybe at the edges, but the histology is much better for that. So I'll show you that distortion in a second. Okay. We'll start with our first section on this case, but a lot of the deeper sections are better. Here we go. Yeah, let's do the circles first. It's a little globe. Maybe we even get away with a slightly higher magnification, can we? I think we can. All right. So here's what our initial section was like. Again, we have this area where we can follow the sclera around, and then there's this more disorganized pink tissue, so fibrosis, that bridges this gap where the sclera slightly curls inward, and it also extends into the globe. And again, we still, at this magnification, can't really make out much evidence of a lens, but let's see what we see when we get closer. The optic nerve is not well sampled, kind of tough to catch it in a case like this with a posterior rupture site right nearby. So, closer look. So one of the really interesting things about this case, we've got cornea up here. So there's that, but there's more pink tissue right here. Let's go a little bit further back to help illustrate what we're seeing. So this is a better view of basically the distortion I was kind of trying to point out on the gross. We've got this dense collagenous tissue coming in here. It crosses the anterior chamber. It dissects into the supraciliary space here. So we have the iris here. We have the first ciliary body plique coming out here, and this pink tissue is dissecting into the supraciliary space or extending into there. And Descemet's membrane, we have one end here and another end there. So there's a peripheral rupture or break in Descemet's membrane, fibrous tissue that's crossing the anterior chamber like a membrane, and then it's into the supraciliary space. We can take a closer look at that to confirm everything that we just said. Here's the end of Descemet's membrane on one side. You can see the Descemet's membrane is also doubled, which is kind of a common thing that happens when Descemet's is disrupted. And maybe I lied, and there we go. Here's the other end of Descemet's. I pointed out in the wrong spot on the lower magnification image, but here's the other end. So we have a peripheral rupture, and then that distortion extending into the supraciliary space and distorting that ciliary cleft. So most likely what we're looking at here is during the initial trauma for this dog, the iris and the ciliary body, let me get that in better focus, sort of, eventually. Okay, the iris and the ciliary body would have peeled away or torn away slightly from their normal anatomic location. And then that space over time filled up with fibrosis, so scar tissue basically. And so when the iris and the ciliary body tear away from their anatomic location like that, it's called cyclodialysis, which is pretty much just calling it like it is, dialysis, tear, cyclociliary body. So tearing of the ciliary body. Another feature is this, not that end, and that end, showing off the peripheral break of Descemet's membrane. Peripheral breaks in Descemet's membrane are pretty common with blunt ocular trauma. The force when the cornea is hit with something tends to distribute out to the periphery. We'll sometimes see those peripheral breaks in particular. So all consistent so far with the trauma in this case. And we can track that sort of anterior chamber membrane to the other side. And the iris is sort of unclear on this side, so lots of distortion and tearing of the anterior uvea. And then while we're over here, before we move too much further away, the conjunctival fornix is way up here. You can follow the limbus here. So this is the deep corneal stroma. This is the scleral collagen. You can see the slight difference in staining in those different collagens and the melanocytes that kind of mark where the limbus is at. And the iris base, however, is way back here. So that's an angle recession, and or just this is a consequence of the cyclodialysis, and it healed kind of funny back into place, not in its normal anatomic location. So just a walk through how distorted trauma has made the anterior uvea. In addition, if we go back to the big scleral rupture here, we see something that we've been looking for a while. So we have this nice dense collagen of the sclera, but it just sort of peters out. And we have this more disorganized collagen of the fibrous tissue and this tightly fused orbital muscle into that site of scleral rupture. But we also have fused into this fibrosis in the posterior globe, this extremely crinkled up basement membrane collagen, nice and homogeneous. And this is the lens capsule. So we have a ruptured lens capsule that is fused to this site of rupture in the globe. And the lens fibers are completely resorbed, maybe expelled. Actually, this is one of the prettiest things. You can see this site of rupture in particular because we have that lovely curling, tight curl of that posterior lens capsule. Very pretty to see, which helps us to, if we needed any additional evidence that this was truly an in vivo lens capsule rupture, there it is. So this is lens capsule rupture with hypermature cataract and resorption of most of the lens fibers, and it just stuck down onto the site of globe rupture in the back here. So long story short, we told them what they already knew. This is a really good example of what blunt ocular trauma can do to the eye, especially give it a bit of time to heal and do its thing. Before we move on from this case, just some interesting features. I believe SF2. They described some corneal changes, which were also part of the reason why this dog globe eventually got enucleated. And here we have the cornea. So we have that distorted angle again to kind of orient you. And then more towards the central cornea or axial cornea, we have this area of epithelial hyperplasia and formation of a subepithelial cleft. So we can see at the edges of this corneal epithelium here, it's still attached. It has a nice basal layer polarity. All those nuclei are lined up nicely. And then suddenly that basal layer polarity is lost. And there's a cleft between the epithelium and the stroma. So we call this a subepithelial cleft. If I see an ulcer, an actual area of epithelial discontinuity in our sections, I can call it an indolent ulcer. That's also what the non-adherent flaps of epithelium look like in indolent corneal ulceration. And just as they described clinically again, there's this lovely superficial stromal mineralization right in that area of detachment. And here's the other side showing something similar. You also have this other nice feature of epithelium that's kind of lost its way and become detached. There is this formation of intraepithelial whorls or eddies. Another sign that the epithelium has kind of lost its detachment from the basement membrane and sort of losing its way and its orientation. So that's this case. Some interesting corneal complications that eventually led to the nucleation of this globe that had a very, very old trauma several years ago. All right. And a long list of diagnoses, most of which were related to the trauma. I didn't show you the optic nerve head atrophy, which I suppose we could go back for that. No, never mind. We're not going to go back for that. So anyway, this long list of diagnoses associated with trauma. All right, I will hand the floor over.
All right.
So this next case that we have for you, we clearly do not have a gross image of, but this is from a a 10-year-old Norwegian Bayhund dog that comes with us for the history that they had a orbital mass diagnosed back in February of this year that we actually received a biopsy from, and that I will show you. And then they performed radiation therapy in March. And then there's sort of just a gap in the history, and the owner came back in July because the left eye of the patient was painful. And at that time, there was diffuse keratitis all the way around the cornea with edema. They were suspecting a fibrin plug or fibrin or hypopyon in the anterior chamber. And there was a limited exam, and there was some glaucoma with an IOP of 25. So they enucleated, wanting to look for radiation side effects. Mid-July, the CBC chem was unremarkable. And what I have is that there was no workup or staging since March after the initial diagnosis. So I'm going to start with the initial biopsy that we received from the orbital mass. So we have some nice punch biopsies of mass here that is composed of spindle cells. And the matrix between the spindle cells is this hypereosinophilic material with some embedded round cells in it, so consistent with osteoid. And so we diagnosed this out as an orbital osteosarcoma, possibly a paraosteal osteosarcoma, based on like the radiographic findings that were initially received with the initial biopsy. And so then we received the globe. They didn't tell us, oh, this is the left eye, sorry. We presume that this is on the same side as the orbital mass, although the laterality of the orbital mass was not necessarily given to us, either initially or with the second submission. So here's our subgross view. The retina was detached. And there's some corneal changes that I'll show with some conjunctival changes as well, but not too much to see subgross. So I'll start up at the front here. So the corneal epithelium is very thin throughout, and then the underlying corneal stroma is infiltrated with lots of neutrophils. There's fibroplasia, even some blood vessels in here as well. So some pretty good corneal disease there. There's a little bit of corneal or conjunctival hyperplasia and squamous metaplasia in the conjunctiva as well. A little bit. As well as a conjunctivitis. Looking back at the iris here, there's a thick pre-iridal fibrovascular membrane that lines the front there and causes quite the ectropion uvea. So the tip of the iris leaflet is being pulled forward anteriorly into the anterior chamber. And here we can see it on the other side, where it's just the tip being pulled forward. There's some hemorrhage here at the peripheral cornea. Here is the retina that is detached. It's got multifocal areas of hemorrhage and necrosis that's torn. Here. And as we look closer, we've got blood vessels here in the retina, but we also have this eosinophilic material that is also in the retina as well, that looks a bit more like lens fiber protein. So this is lenticular metaplasia in the retina. So again, some fibrin and hemorrhage from the detachment here, and a little bit of gliosis in the optic nerve. We did get some periocular tissues with this eye. So we got some orbital tissue, conjunctiva, some skeletal muscle, and our third eyelid here. Which is inflamed, has variable hyperplasia and squamous metaplasia with some reedy peg formation. And all this pigment down underneath here is some pigmentary incontinence. And then as we go towards the base and look at the gland of the third eyelid, you can see that it is quite atrophied. And there's a lot of fibrosis and edema in between where the acini should be here. So there's loss of the gland, a little bit of inflammation as well to go along with that.
Can we go back to the globe and the retina real quick? So I'm a little bit skeptical of the lenticular metaplasia.
Okay.
Because so normally we should be able to very clearly identify bladder cells, and also, which I didn't really appreciate there. And also we have a necrotic retina that has vascular, like crazy vascular necrosis. So more than likely this is going to be kind of fibrin or some sort of exudation out of the retina. And lenticular metaplasia is usually in like traumatized or like sort of like abnormal eyes for either developmental reasons or there's some sort of long-standing. So anyway.
Is it really metaplasia then, or is it like implantation of like lens proteins? You know,
it's metaplasia.
When
we see it, it's metaplasia.
That's interesting. So
Yes.
I mean, in the retina, lens fibers.
Miller cells have the capacity to
Uh-huh.
undergo lenticular metaplasia.
Okay.
It's much more common in traumatized bird eyes.
Okay.
That's like the classic place to see it. It's much more rare in mammals. We do have a couple documented cases, but usually there's something going on that's very different sort of pathological picture that we have here.
So, and then from the mass that y'all got earlier, I mean, like I could make a case for this being osteoid as well. I mean, just because like I'm not used to seeing it, so I don't. Do you think it's connected at all to that mass, or?
We don't have any of those neoplastic cells here.
Yeah.
So,
Yeah,
but that's a good thought.
Good thought, but I think it was mainly orbital.
Mm-hmm.
I don't think there was any history of intraocular. And it would have been weird for the osteoid to be just in the retina like this.
Yeah, okay.
Yeah, but yeah. 50 Shades of Pink. As
Welcome to pathology.
Right.
So again, for the previous orbital mass biopsy, the osteosarcoma, and then the ones that I sort of separated out at the top, the diagnoses 2, 3, and 4, maybe -3, since it may not be lenticular metaplasia, but changes we associated with the radiation therapy, the necrosis and hemorrhage in the retina, and the third eyelid gland atrophy and changes there. The corneal and conjunctival changes could have been caused by the radiation, but we also couldn't rule out a degree of like exposure keratopathy or secondary changes from the sort of decreased function, possibly from the third eyelid gland, from the changes from radiation. So there's a little bit of that going on as well. Okay. All right.
Not,
Mhm.
yeah, it is, and that radiation damage, that's from like trying to irradiate an orbital mass, like if you tried to irradiate an ear or something, we might not see that unless.
Yeah, I don't, to be honest, I'm not gonna pretend I understand the technicalities of how to assess the site for radiation therapy, but anything that's in the face that the eye may be exposed causes a risk. And there are ways to try to avoid, exposure, but I think especially in the orbit, it might be hard to not expose the eye to some of the radiation from the treatment.
That's very cool.
Mhm.
So it's where I feel like we see a lot of vitritis and not necessarily dry eyes. So
Cool.
I feel like that's something we see before we see their eyelid and macular degeneration.
And it often causes cataract, right, which this one
Yeah.
didn't have, but yeah.
Right, the lens was okay in this one.
Interesting.
Cool. All right. All right, so next up, spoiler alert. So this is from a 1-year-old domestic short hair cat. This is the right eye that was non-visual, absent menace, had corneal neovascularization, and unable to visualize the lens. So grossly, we've got lens up here, or sorry, cornea up here. But yes, the lens was a little bit unique and weird looking when I sectioned it. And so I took a picture because instead of a discrete looking lens, there's just this white solid material that has these like spikes coming off the back of it. Here, got a little bit of maybe some detachment or expansion of the suprachoroidal space. And then when I took the kind of the cap off of the hemisection, at the top here, I sectioned right through a wooden foreign body in the eye. So that is what I'm going to show you in my squeaky chair.
It was from radiation therapy to a big chunk of the wood. Get more black.
All right. All right, so cornea up at the front. Got this kind of darker purple or pink here, where is remnant lens. We've got all the protein fluid in here. This wrinkled material here is the retina. And then as far as sectioning artifact, here is the foreign body that was outside the eye. I'm not sure if it fell out during processing or if the histotechnicians needed to move it so they could get a nice section for us, but at least it is still on the slide. All right. So cruising around, again, we can see this nice proteinaceous material in the anterior chamber. And here is our iris. I don't think we have a very good section of the pupillary margin here since I had to flip it over so we could make sure to get a section with the stick in it. But everything is infiltrated by lots of macrophages and neutrophils. Here are what's remaining of our lens fibers. So you can see inflammation coming through and dissecting through the lens fibers. And these lots of neutrophils and macrophages. Here's some wrinkled lens capsule. So our stick ruptured the lens capsule. Here is our accordion style retina going across here, which is also got some inflammation in it, lots of protein in the subretinal space. And we don't have optic nerve, but in the posterior sclera here in the choroid, there is a defect and discontinuation that's kind of replaced by some fibrosis. And if we follow it out, it's probably a little tract here from where the stick entered the eye from the back of the globe. All right, and then here is our section of our foreign body. Looks pretty consistent with plant materials. It's surrounded by macrophages and neutrophils. And then it's accompanied by lots of bacteria and pigmented fungal hyphae. So nice contamination here. Let me see if I can polarize this, I think.
It's still pretty.
So pretty. Yeah.
The chromotherapy section.
Yeah. So, yep, contaminated foreign body entered the back of the eye, probably maybe through the oral cavity, given the location, or migration from somewhere back there in this very young cat. So that was fun. And that was all I had. Oh, and the diagnosis. I guess I should finish and share the rest of it. Opa. Opa. Yep. So severe pyogranulomatous, lymphoplasmacytic endophthalmitis, anterior uveitis retinitis, with that focal defect in the posterior choroid and sclera, consistent with the penetrating tract and the contaminated foreign plant material. Lens capsule rupture and the retinal detachment and inflammation. So
given that it was coming from behind the eye, maybe it came up from the oral cavity.
yeah.
It's kind of,
It really
Usually
doesn't look like a migrating on like
Yeah.
you usually see. It looks more
stick,
sticky.
an actual stick in the eye.
An actual
Stick.
stick in the eye.
Which
Yeah, that's
is,
how we call those.
which is interesting. This is a cat. We think of dogs like chewing on sticks and like,
Mhm.
you know, something migrating up from the oral cavity, but cats don't usually do that.
Yeah,
Interesting.
an internist told me, dogs eat things by accident, cats eat things on purpose.
Interesting. Okay.
Oh, I
Yeah.
don't know.
Yeah, anyway, it's kind of an interesting case.
Yeah.
Cool.
Thanks, everyone.
All right.
Yeah.
Thanks, everyone.